So the left bundle branch area pacing, that's a concept recently developed in the last few years. It's originated in China, but the original concept came from the Dutch group where Fritz Prince and others worked on placing a lead in the deep septum and trying to get into the conduction system. Even though they didn't prove conduction capture, the new method of pacing in the left bundle branch area, we are able to do that. So this is a simpler way to place a lead through the right ventricle and place into the LV septal surface. And thereby you can achieve capture of the entire left bundle fascicles, and the left ventricle activation is physiologically simulated. So it reduces the risk of ventricular dyssynchrony in those patients. So one of the recent developments is the Hispano Pacing. So Hispano Pacing, we capture the both right and left bundle, and it works very well in most patients. However, there are patients who have significant conduction disease, a little more distal in the His bundle, and often you have disease in the proximal left bundle, or patients who develop complete disease in the His bundle and develop heart block. In those patients, we have trouble with higher pacing threshold with Hispano Pacing. So that is a group of patients that gives a great alternative for those patients. So when you have conduction disease distally, we're able to bypass the site of conduction block and get into the left bundle branch and able to capture them. So that's one group of patients who are pacemaker type of patient that will benefit from left bundle branch pacing. The second group of patients where I think it may make a huge impact is patients who have cardiomyopathy and who have left bundle branch block, where the cardiomyopathy is primarily related to the underlying electrical conduction disease. So pacing at the left bundle, we are able to completely normalize and synchronize the heart, and it may have a big future in terms of improving heart failure outcomes. So we have started using left bundle branch pacing for the last year. So we presented data on the last 100 consecutive patients who underwent an attempt at left bundle branch area pacing. These were mainly patients who needed pacemakers for AV block, patients with sinus node dysfunction, those who failed left ventricular lead placement for cardiac resynchronization therapy, and some patients who failed Hispano Pacing lead placement. And so we were successful in 93% of these patients and able to achieve left bundle branch area pacing. And the second thing we did also, we were able to describe the electrophysiological characteristics of how left bundle branch capture can be confirmed. And we were also describing the echocardiographic findings in these patients in regards to the location of the lead, in relation to the tricuspid valve, in relation to where in the septum and how deep in the septum this lead is. So it gives us a better understanding of how this new technology might work. This is a very early technology. We are using leads that are not designed specifically for left bundle branch area pacing. So traditional leads, we have the lead attached to the myocardial wall for about 1.8 millimeter screw. Here we are trying to advance the entire lead body from the tip to the ring of the electrode, about 10 to 15 millimeters into the myocardium. So we don't know what is the long-term effect of the myocardial contractile force on these leads. One thing to concern about. Second concern that we have is what if any of these patients need lead removal, extraction, how easy or difficult it's going to be. So those are things that we need to understand. So those risks, and then what about long-term risks of whether the lead moving out into the left ventricular side or falling off into the RV dislodgement. So those things have to be better understood. And lastly, we need to build clinical evidence showing that this technology works and it has a positive impact in terms of managing patients with rhythm problems.